It is my absolute pleasure to welcome Dr. Jha here to the 5th Annual Global Health Economics Colloquium. Ashish is one of the foremost thought leaders on healthcare quality and value in the country and indeed in the world. His trajectory, he was born in Bihar, as I learned yesterday, went to med school at Harvard, and then quickly corrected his ways and showed up at UCSF for a residency. Clearly a very transformative experience. He's back in Boston and is now the director of the very influential Harvard Global Health Institute and the senior associate dean at the Harvard T.H. Chan School of Public Health. He has an incredible social media presence. I feel like so much of the most cutting-edge issues in public health I learned from his tweets, and I'd encourage you to follow him. But he is now as we were trying to figure out a topic for Ashish, he pointed out that he is on the National Academy's Medicine's Committee on Universal Health Coverage. And as you know, universal health coverage is indeed the mantra of global health of our times. It's the be-all, end-all. It's going to fix all our problems. It's what everybody needs to do before the world can be a better place. And I'm only saying that in half jest. The truth is that India just adopted the most ambitious universal health coverage program ever announced this past week without actually having any details on the ground on how it's going to work, which, if you know, is par for the course. I can say that. I grew up in India. And what Ashish is going to talk to us about is UHC the right strategy forward? Is it necessary? Is it sufficient to improve the health of the world's poor? And with that, Ashish, thank you.
Okay. Can everybody hear me okay? So we have about, by the way, Kazi, thank you very much for an unnecessarily generous introduction. And, like, you should not be getting information from my tweets. Like, just... so we can have a conversation about that afterwards. But I am delighted to be back home. This is home. It's where you train, has this incredible imprinting on how you think for the rest of your life, and UCSF certainly has that for me, so I'm delighted to be here. I put this talk together really for this symposium as a way to think out loud about a bunch of issues. And so I give a lot of talks where it's like, I've been thinking about it for a long time, that's the 7th time I've given that talk, it's polished. That's not this. And I felt like I'm going back home. I've got lots of friends in the audience. I'm hoping I'll have almost as many at the end of the talk. And so I thought I would try out a bunch of thoughts with all of you. We have about an hour and 10 minutes. It's a great size group that I think we can actually have a discussion. So my goal is not to fly through all my slides and then have 15 minutes of questions. I would much rather if you stopped, interrupted me along the way. I have several obvious break points in the points that I'm going to make. But if we make this interactive, it's going to be a lot more fun. And if I don't get through all my slides, that's totally fine. So my only request is please interrupt, please ask questions. And especially when I say stuff that you disagree with, definitely push back. Okay? Great. So here's the agenda. I'm going to spend about 5-7 minutes reminding us that this is an extraordinary moment in global health and really an extraordinary moment in health. And I'm going to talk a little bit about why that is from a global perspective. And we certainly saw this in the US. The last 7 years, healthcare and health has dominated the political conversation. When you're inside the healthcare system or the healthcare field, you can take that for granted. For all my friends who don't work in healthcare, they find this extremely frustrating because they're like, you guys have sucked up all the oxygen for all political conversations. It was by far, the ACA was by far the most consequential policy intervention made by the Obama administration. It has been repealing it has been the sort of rallying cry for the Republicans. The global nature of the conversations around universal health coverage have really sort of taken on center stage, not just in the global health community, but in the global community. So I'm going to spend 5-10 minutes reflecting on why I think healthcare, from a global perspective, has gotten to be so incredibly important. I'm going to make the case for UHC in very sort of quick terms because I feel like this is not an audience that needs to hear the case in any great detail. But then I am going to walk through 3 cautionary issues. 3 things that ought to give us pause, ought to sharpen our thinking, ought to be things that we are thinking about and dealing with if we're going to get UHC right. And I believe, and I'll start with this, that the risk of getting UHC wrong so that we end up in a worse place than we are today is very high. And the people who will suffer from that will be the world's poor. So there is some hard thinking that needs to be done on UHC, and I'm going to try to lay out at least a few of those issues. And then I'm going to sort of finish up by saying, where do I think we could do this well? Okay? That's the agenda. So first 5-7 minutes kind of level setting on why healthcare is so important. So why is this a global health moment? First, health has become the biggest sector of the world's economy. And this is really a phenomenon of the last decade. It's about 10% of the gross world product. We think about GDP for countries. Right? The global economy produces about $78 trillion of goods and services every year. Okay? That's the economic output of the world. And healthcare spending is about 7.5 trillion of that, so about 10%. Okay? It's big. It's big globally. And it's growing rapidly. Right? It will reach about 18 trillion in 2 decades. One thing that is very important to understand, and I will show you some data in about 20 minutes that will reflect on this. When healthcare rises faster than the economy, the dollars are coming from some other sector of the economy. Right? So when I say healthcare is going to grow faster, I didn't say that, but the implication is it's going to grow faster than the rest of the world's economy, and it will. That means there will be dollars coming out of other areas that could have seen comparable growth. And so it's worth thinking about this issue of trade-offs. But the point is, it's big money. Why has healthcare become so big and so important? I think there are several factors. I kind of want to highlight 2 of them. One is demographics, and I don't just mean the aging population, but I mean the fact that we have a rising middle class. And that has really happened since the 1990s. We've had this massive upkick in the number of people who are middle class. There are about 7.5 billion people in the world, and we're probably at about 3.5 billion people who classify as middle class. And when you become middle class, you start demanding healthcare in a way that you didn't when you were very, very poor and just trying to make ends meet. And the flip side of this chart is the number of global poor is falling. This is data from the World Bank. Again, this is in millions. So if you go back, 1990, there were about 2 billion people who were poor, and that number has basically been just falling off the cliff. This is, by the way, awesome news. Right? We've cut the number of very poor people in the world in half in 25 years, while the world's population has grown. So this is not percentage of the world's population. This is the actual number of people. This is awesome. Right? Like, there's nothing to say about this except this is great news. A lot of this is China, but it's not all China. Right? So China has had this incredible economic growth that has lifted hundreds of millions of people out of poverty. But it's not just China. We've seen dramatic reductions across Africa, big reductions across South Asia. The world is becoming less poor, and that is fundamentally a good thing. Those 2 things, right, middle class world, that I think is one of the demographic issues. As fewer people are very poor, again, the demand for healthcare services rises. Here's the other part, which is there are lots of ways of trying to characterize new technologies and treatments in healthcare. One is just like new drug applications approved. This has been steadily rising over the last 50 years. And the bottom line is 50 years ago, it wasn't really clear that healthcare did much. Like, we had some treatments, we had some stuff, it worked kind of sort of on most days. We actually now have a lot of very effective therapies that save lives, that improve well-being. Healthcare has become dramatically more effective. And those 2 forces, demand for healthcare and the effectiveness of healthcare, has come together to, I think, drive a lot of the healthcare spending. So healthcare is big and getting bigger. It's becoming useful to individuals and society. So this is kind of one huge reason. The other reason I just want to take a minute to talk about is why global health? So global health is a combination of thinking about health in all the different parts of the globe. But there's another phenomenon of global health that I think is very important, which is the other big thing that's happened in the last 25 years, is the increased interdependence of the world. And I didn't use the word interconnected, though we are very interconnected, right? I can get on a plane and be in Seoul in 14 hours, and there's all this travel, but interdependent, right? Our drugs are manufactured all over the world. Our doctors come from all, and nurses come from all over the world. The world has become far more dependent on each other than it ever did. In a way that, without being overtly political, the idea of building walls is insanity. It's symbolism that will have clearly only negative effects, right? There's no way to kind of undo that interdependence. And that interdependence, I think, behooves us to act. And so one of the reasons why global health, so at Harvard, where I teach, at the college, global health is the most popular secondary field, right? It has just become, it has taken off in terms of its importance and its interest. And I think it's because the world feels very interconnected, very interdependent, and makes people want to act on issues that are happening around the globe. There's also a sense that stuff that's happening across the globe will have an impact on me. And those two things coming together, I think, has made global health a very important part of the field. So any kind of, before I move on to talking about what kind of action this has spurred, any comments, questions, reflections on that? Yes, sir.
You said it was the second most popular discipline?
It's the most popular secondary field. Sorry, we don't have minors, and you can't do a major in global health. So it's a secondary field, or what's essentially a minor.
And you think it's because people are interested in helping global health, or is it the increase by, like, was it 11 trillion in the next couple of years?
Right. So I think there are two parts of it. I think, first of all, for people who want to make money, global health or healthcare is a very lucrative thing. But I'm really talking about global health, which right now, for a lot of people, still feels much less about making individual riches and much more about contributing to the world in a meaningful way. So I think that's what's driving it, at least for the students, for undergrads, for graduate students. Yeah.
Is it because NCDs have actually displaced acute infectious diseases as the cause, and no developed or developing country knows what to do about it?
So I think two things. First of all, I think acute infectious diseases still remains, of course, a very large problem in large parts of the world, and coming back in the developed countries. So I think that agenda remains. I think the fact that NCDs have become a bigger issue does in some ways tie us all together a bit more. I mean, I think that's a bit your point as I understand it, that cardiovascular disease is a problem in San Francisco, it's a problem in Boston, it's a problem in Botswana and Bombay, right? It's, so that's I think that is part of it. Maybe one more back there and then we'll keep going. Yes?
My question is, why doesn't Harvard have global health as a primary field? It was a very new major, and as soon as I heard about it, I switched from biochem. I actually was going to triple major. I was going to do biochemistry, Spanish, and religion, right? And then as soon as I heard about global health, I was like, oh my god, that's everything I ever wanted in a major. And I realized, so I'm actually very shocked to hear that Harvard, which is, you know, one of the vanguards of,
I opened up a can of worms. Yes, please keep going.
Harvard, but...
So first of all, I do want to say we have a secondary field in global health, for those of you interested. And you know, what constitutes a major, and like how much of it is discipline-based, and where would it sit? I have not, to be perfectly honest, gotten into those conversations, but I think your point is well made, that this is a topic that, I mean, is clearly cross-disciplinary. It brings people together from across fields. And there's no reason we can't have majors. We do have other majors that do that. So, but why Harvard has not done it, no one's asked me, and I have not waited. All right, we're going to do a couple more questions. Yes?
So I guess mine's, I'm not sure question or comment, but it's sad for me to see what you're saying globally is happening, whereas nationally here, it's the direct opposite, right? Our middle class is shrinking, you know, our poor is getting higher. I'm just like, how did we as a developed country get to this point when the world is actually doing much better overall?
Right, the world is doing much better. I'll try to repeat questions you're asking. It feels like in the US the trends are going in the wrong direction. Certainly in the last 3-4 years we've seen some reversals of long-term beneficial trends around life expectancy, a struggling middle class. So I think again, I don't want to turn this into a longer conversation about American social policy, but I agree that the broader global trends does not mean every country is on the same trend or the same trajectory. All right, that was your question. Great, okay. So all of this, as I said, has kind of spurred on a lot of interest. And what has happened in the last, I'd say, 3-4 years is this incredible focus on UHC, right, and universal health coverage. And it makes sense to focus on coverage. Actually, before I get into it, I mean, just to reiterate for those of you who don't know, Dr. Tedros, who's the new Director General of WHO, I mean, not that new, came in July, has made universal health coverage like the organizing principle for what World Health Organization is going to focus on over the next 5 years. And there is a lot of benefit of that, and there's a lot of reasons, and we want to talk about that. But part of that is he is going around and getting countries to commit to UHC. The huge commitment from India, it is literally hundreds of billions of dollars. This is now like the topic in global health. And as I said, it makes sense to focus on this. It makes a lot of sense to focus on UHC, right? We know people often can't afford care, and the notion behind it is coverage should allow people to get the care they need and improve health without going bankrupt. That's the motivation for UHC, like in a nutshell, right? And if you talk to anybody and say, so what are the main goals of universal health coverage? I'll give you the official definition of universal health coverage in like 2 slides. Every talk should have one. But it's basically 2 things. Financial protection, make sure people don't go bankrupt when they get sick, and improve health, right? Those are the 2 goals. And if we can accomplish those, that's good. And so here's the World Health Organization definition of universal health coverage. It's got a lot of words, but the key principles are it's about universal, all people, getting health care of sufficient quality, and we're going to spend a bunch of time talking about what is sufficient quality, and that does not expose the user to financial hardship, right? So those are the kind of principles. This is the World Health Organization definition. Okay. So the question that I'm going to now, yes.
What does
Yes,
sufficient
please.
quality mean? Because is it like perfect quality?
Sufficient.
Oh,
Sufficient.
Sufficient.
Yeah.
Okay. Thank you.
Yeah. Any other questions? Any other clarifications I can offer? Now, so those of you who believe in insufficient quality, it's not going to count. It's got to be sufficient. It is purposefully vague because the notion behind it, so I'm joking, and as were you, I know, but here's actually the principle behind it, which is, so you say sufficient for what? And the argument is it's sufficient to improve health outcomes. It's got to be good enough that it's making a real positive difference in people's lives. That too is vague, but at least it starts getting us directionally in heading towards this. Yes?
I just wonder if you have any thoughts about why they didn't use necessary instead of sufficient.
Like they would have
Necessary quality?
Yeah, necessary quality. And that would tie to real kind of outcomes goals.
Right. Yeah. So, for those of you who've ever been part of a WHO definition creation process, I've been part of one. I can only imagine how many people over how many meetings led to that. And so, what kind of bartering went off between the representative from Sri Lanka and the representative from Sweden to get the word sufficient and not necessary? I don't know. But the concept is it's got qualities in there, right? Qualities in there, and it's got to be sufficient quality. I mean, I'm kidding a little bit, but the point is these things are meant to be a little bit vague because they're supposed to be directional and not constraining. If you make it very tight definition, then the whole world has to live by that definition, and that becomes difficult. So a little bit of looseness in definition is actually really helpful. Okay. So the question is, will this get us there? And I'm always reminded, so here we are at UCSF. This is a joint effort, UCSF, Berkeley, UW, Stanford, and all of us in education. The task of education, and this is one of my favorite quotes from the Reverend Martin Luther King, is the function of education is to teach one to think intensively and think critically. And I want to spend a few minutes thinking intensively and thinking critically about what we're doing on UHC and whether it is going to get us where we want to go. Okay. So I told you that there are 2 big goals of UHC. One is financial protection, and the other is outcomes. And the financial protection should be easier, right? Like that's the part where we're like, well, we should be able to just financially protect you. The underlying delivery system and quality, that's harder stuff. So will UHC get us financial protection? This should be, as I said, the easier of the two bars to hit. This is from a paper that came out last week in Lancet Global Health, looking at the incidence of catastrophic health spending around the world. I'll show you the global map. You can't, I mean, again, it's got lots of little numbers and it's hard to see all of this. But they define catastrophic spending as when people have to spend more than 10% of their household income on healthcare. They also use a different definition of 25%. But if you think about it, for like a family of four that might make $50,000 in the US, $5,000 of healthcare spending in a given year can feel like pretty substantial. And obviously, once you get to 25%, that is truly catastrophic. So a couple of things. First of all, what you see is lots of variation around the globe. You know, no surprise, Canada tends to do pretty well. America does a little bit worse. But it's interesting, some of the European countries tend to have higher, darker colors than you might have assumed. It was a bit of a surprise to me. When you dig in, and this is mostly based on World Bank data about income and healthcare spending. But what's interesting about this is you realize that not all UHC is the same, and I'm going to just share two countries. They're not two completely random countries, because they are China and India, together about 40% of the world's population. If you look at China, it has 90% healthcare coverage. It's close to universal health coverage. People often talk about China having UHC. Here's their percentage of the population having catastrophic spending. And here's India with almost opposite coverage. Almost no one has coverage in India. And here's their proportion of their population having catastrophic spending. Now, I didn't just pick two random countries. China and India really, as I said, 40% of the world's population. I could, just from this paper from the Lancet Global Health last week, show you about 30 other countries where there just seems to be this disconnect between proportion of people covered and catastrophic health spending that bankrupts people. So what's going on? Like this doesn't this bother anybody? Because it shouldn't work this way, right? So what's going on? Any thoughts? We can talk about it either specifically to these two countries, or we can talk about it in more general terms. Yeah.
Thank you. I'm from Brazil.
Yeah.
We do have coverage, but we do spend a lot because the quality is not good. So if you have any extra bit of money, you would invest on that instead of staying in lines for ages.
Right. So
Get what you need.
one part is people have coverage through public systems, but the quality of the public system is so bad that they spend exorbitant amounts of money going to the private system.
Yes.
So the question is, do they still have coverage or do they not? And the answer is yes, they technically do.
Yeah.
But they're spending a lot. Yes.
Zeke Emanuel reconfirmed the notion that, at least in the United States, 50% of all healthcare spending is spent in the last month of life. Is that true for these other countries?
So the numbers are not, unfortunately, thankfully, not quite that bad. But you're absolutely right that there's very substantial healthcare spending at the end of life. There's a really nice paper in JAMA that Zeke saw on that looked at end-of-life spending across 13 high-income countries and finds that across all 13 high-income countries, the proportion of spending in the last 6 months of life is essentially identical. So that is not a uniquely American phenomenon. Don't know, no idea, no data on China or India. But again, across high-income countries, it's about the same. Yes, Kazi.
I guess it depends on what we're counting as healthcare spending. Is it just the healthcare or all the associated spending, the taking time off work to go get health use, et cetera?
So this is primarily spending on healthcare directly. This is primarily spending on healthcare directly. Any other thoughts on what could be going on here? Yes.
Part of what seems, or at least what I hear with India, is it's a very competitive market because people don't have coverage.
Yeah.
They're bargaining for price or looking for actively the best price. So
Yeah.
what we call the skin in the game argument.
Yeah.
Which does keep prices low there.
Yeah. So that helps explain why maybe it's only 17%. But why is China as bad given this very substantial coverage that they have? Yeah.
Is the coverage financially limited, so it's only covering a few things, and when people get really sick, they're not covered for that?
Yeah, so it's very broad coverage and very shallow coverage, right? It's very shallow coverage. So for people who are not very sick, it's great coverage. But the moment you become sick, you like blow through your max, and now you are into the wild, wild west of no coverage at all. So it's the shallowness of the coverage that gets people into trouble in China. So one lesson out of these two countries, or at least out of China, is you can't just say we've covered everybody. You got to talk through, well, what have you covered, how much, how deep, and why would you do shallow coverage? Because the money's got to come from somewhere. And if you go deep coverage, it's just much more expensive, right? One of the things people who loved beating up on the ACA exchange plans was they're like, oh, these are more expensive than what many people used to buy. Yeah, because it was better coverage. Get rid of lifetime caps, it's going to be more expensive than if you have lifetime caps. So the point is, coverage is not coverage is not coverage. All insurance products are not the same, and you got to look at the details. Because one of the things that we're discovering is there are a lot of countries that are committing to universal health coverage. There are a lot of countries who are putting resources in. And we're not moving the metric on catastrophic healthcare spending that much. Yes?
Why do you select the percentage of catastrophic spending as the metric for sufficient care?
For sufficient care?
Yeah, you said that universal coverage has to provide sufficient care.
Oh, yeah. So
So you selected a metric that may not be the right one.
Yeah, no, so I said there are two metrics. I'm going to cover each of them separately. One is sufficient quality, and one is financial protection. This is about financial protection. So we'll talk about sufficient quality coming up. But this is not meant to cover sufficient quality. This is not a quality measure. This is financial protection measure. So if I misspoke on that, I apologize. We're talking about financial protection and whether universal health coverage is generating financial protection. And I think what we're seeing in the countries, and if you go back to the last slide here, is there are a lot of countries where it looks like there's universal health coverage and still pretty substantial amounts of catastrophic spending. Article last week in the not Boston Globe, Toronto Globe and Mail, the number one cause of bankruptcy in Canada is healthcare spending. Canada, which actually is pretty deep, but there's chunks they don't cover. They don't cover drugs for most people. And so if you require expensive drugs, it can become very problematic very quickly. So my point on this simply is UHC is not an automatic panacea for financial protection. It depends enormous amounts. I'll get you in 1 second. Depends an enormous amount on what's covered, how deeply it's covered, where the dollars are coming from. Yes, go ahead.
So I like that you're breaking it into these two things, but aren't they interdependent in that as you keep people alive longer, you increase the chances that they, the accumulation of spending.
Yep.
So they're more likely to then have catastrophic health spending.
Yep. So I think, look, I agree. These things are all interlinked. To some extent, it's helpful to just look at them individually, and then we can talk about where they overlap. But again, one of the principal goals of a UHC is, at least in the short run, to reduce the number of people who are going bankrupt, who are really getting into big financial trouble. And the data so far is it's helping on the margins only. It's not making a big impact on financial protection in a way that it's supposed to. Okay? Any other questions or thoughts on that? Great. Here's the line, the final sentence from that paper. Catastrophic payment incidents cannot be, this is not the most elegant way to phrase it, but you'll get the notion here, cannot be inferred from the fraction of population covered by health insurance schemes or public health services. This is another way of saying you can't just look at how many people are covered as a way to figure out how many people are going bankrupt. Right? So UHC is not like, oh, we're 98% covered. That's too vague, too broad, not enough meaning. Because the goal is not 98% covered, the goal is financial protection. Okay, are we good? Any questions on that? I promise we'll get to quality. And what is sufficient quality? We'll answer Jim's question. Okay, so this is where we're going to now spend a bunch of time talking about whether UHC will get us better outcomes. And the mental model that we've had on this has been sort of this, will coverage lead to better health outcomes? And I'm going to just, again, in very kind of quick terms, highlight what I think the state of the evidence is, and then I will dig into a lot more details on the evidence. Okay? So what's the evidence that coverage leads to better health outcomes? If you had a way to try to put all the data together, I don't have a slide on all the studies that have been done. But if the question is what's the evidence that increasing healthcare coverage really has a big impact on health outcomes? What I would say is in high-income countries, it's mixed, but more positive than not. For those of you who've been following the debates of the ACA and Medicaid, It's been very controversial, with a large number of people saying that Medicaid expansion has not made an impact on health outcomes. Another large group of people saying it has made an impact on health outcomes. My read of it is that all else held equal, if you really look at the totality of the evidence, it probably has had some moderate benefit for improving health outcomes. It's clearly helped for financial protection. But from a health outcomes point of view, Medicaid expansion probably has helped. But that's in the US and in other high-income countries. If you look at studies and data from low and middle income countries and ask when countries put in some sort of a coverage program, did we see improvements in health outcomes? Almost all the studies say no. Right? And so the question is, why not? And this is the part where I think we need to talk about this idea of sufficient quality. And I'm going to come back to the WHO definition and remind us, we've spent more time talking about sufficient quality than I was expecting to, but remind us that that's the goal. So what do we mean by quality when WHO or others talk about quality? There are lots of definitions. I'm going to give you a very simple one that fits pretty much with what WHO has argued is quality and fits very well with the Institute of Medicine's definition. But generally, people think about, in the global space, sort of think about quality as having three things: care that is safe, right, doesn't harm patients; care that is effective, consistent kind of with the best professional knowledge; and care that is patient-centered, kind of meets people's needs and values. Again, I realize each one of these things we could spend 20 minutes talking about. I just want to give a highlight overview of when people talk about quality, that's what they mean. And if you think about it from your own personal perspective, if you go to the doctor, if you go to the hospital, and you get care that is delivered safely, it's effective, and kind of is the best evidence-based stuff out there, and you get treated with dignity and respect, and your values are paid attention to, that's pretty good, right? Like, we call that pretty good care. Okay, so that's my working definition. It's not mine. It's, as I said, it's sort of the WHO's and the IOM's. Okay. Any questions on how we're defining quality? Not how we're defining sufficient quality, but how we're defining quality. Okay, everybody good on that? Yes, back there.
Can we talk about quality without good prevention or good strategy of early diagnostic, particularly in Africa?
Yeah, so early diagnosis, so there are two separate issues, several separate issues. Certainly, population level prevention is a very important thing for population health. Most universal health coverage schemes don't focus on that. They're really focusing on the healthcare system. What happens when the moment you walk into a doctor's office, a clinic, or a hospital. So UHC is very much focused within the walls of the healthcare system. And so the broader population health strategies of taxing tobacco and sugar and trying to get people to exercise more or clean up air pollution are all incredibly important from a population health point of view, usually don't make it into the UHC conversation as we're having it. I'm not saying they shouldn't, I'm just saying they don't. Like, that's where they have drawn a boundary. I would say early diagnosis is part of this. Like, safe and effective care is making an early diagnosis and treating it effectively. So I think that fits in more. Andy.
I know it didn't sound like you were at the discussions about the definition, but do you think the thought of value instead of quality was at all entertained? Because, you know, I mean, part of the issue is quality across every possible service you could get, or in fact, would we get a higher return on investment, say, on the primary care end of the spectrum versus the, you know, inpatient, quaternary type care?
Yeah. So it's interesting and it's complicated because, you know, so in general, the conversation, so value can come in a couple of different flavors. You mean value from a health gained point of view, or do you mean value from a cost of implementing quality point of view? And cost has generally gotten taken out of that initial conversation. WHO is much more willing to have a cost conversation than our government is, for instance. So they will say quality of services that are cost effective, but they still keep those concepts separate. Quality of services that are cost effective. I think, I understand, it's a split, it's reasonable. You could easily intellectually argue for a blending them together, which I hear you arguing, and I think that's fine. I was not part of that definitional process that WHO created. Yes?
This is sort of related to that. If I think of myself as a consumer, or I'm trying to think of the definition of quality in a, you know, a low and middle income setting, it's hard to think of quality without thinking of cost or cost containment in the U.S. So,
Yes.
In fact, you can get very poor quality if they're sort of doing what's safe, it's effective, it's patient-centered, it's just wrong. So
if it's wrong, it's hard to know how it would be effective and consistent with best professional
it eventually
knowledge.
is effective, but it takes maybe 6 visits to get there.
Oh, yeah, so
right?
there's an efficiency and a timeliness to it.
So I would love to see an efficiency and timing put in that definition.
Yeah. So
next time you're on that committee.
well, so let me, there's a long history of thinking about what is the definition of quality, and I didn't want to spend too much time on this, but let me take 30 seconds and say, probably the most influential and probably the best definition of quality comes from the Institute of Medicine in their Crossing the Quality Chasm report. And they have 6 domains of quality: safe, effective, patient-centered, but also efficient, timely, and equitable. And WHO's definition really kind of centers around these 3 things, though more recently they've pulled patient-centered out and said that's a separate feature and it's not part of quality. And then the NHS has its own definition of quality that has these. So the point is, like, there's lots of different definitions, but basically everybody kind of circles around these ideas. But no doubt about it, timely, efficient is a very important set of components within it. And I'm not like I don't have one favorite that's mine. Like, I think all of these guys are trying to about get to the same place. But all of them have these 3. I don't know any definition that does not include these 3. And so I usually use this as a shorthand because this is the one everybody seems to agree on. Okay, keep going. So what is the state of quality globally? That's what I want to spend about 10 minutes on. And I'm going to share with you 2 sets of data. One is just a study that we were involved in for WHO, where we basically tried to calculate, and I'm not going to go into a lot of detail because I want to actually get to the second half of this quality stuff, which I think you're less likely to know. But what we try to do is we basically try to calculate the global burden of unsafe care. Global burden of disease, a pretty standard metric we use to track disease incidence and suffering from disease. And we basically said, can we try, based on all the data we have out there, calculate how many people are injured, how many people die, how many disability-adjusted life years are lost from poor quality or from unsafe medical care. Not from poor quality, but from unsafe medical care, right? And our estimate, this is about 6 years old now, and again, this was under the auspices of WHO, so it kind of used their methodology. We estimated there were about 43 million injuries a year, about 23 million disability-adjusted life years lost. And here's the bottom line. Unsafe medical care is probably one of the top 10 causes of death and disability in the world. So the way we're delivering health care, and not just the failure to provide effective care, but actually delivering unsafe care, is a major public health problem, right? It's up there with a whole bunch of other NCDs and infectious diseases if you think about it as a source of human suffering. And so at least it raises the question that if we give people a lot more access to this stuff, how much good are we going to do? So hold that thought. Unless anybody wants me to clarify any of this, I'm happy to do that, but let me just keep going. Yes?
Is there significant variability in that across?
Absolutely. Absolutely. And there are large variations between high and low income countries or high and low middle income countries. So for instance, in high income countries, medications are a major source of death and disability. In low and middle income countries, the upside of having access to fewer drugs is you're less likely to be injured by those drugs. But they have much higher rates of infections, of healthcare associated infections, and other complications. So the epidemiology looks different, not just in these broad categories, but even across countries. But the numbers look daunting everywhere. Yes?
So Ashish, this access a part of quality here. So if you have safe and effective, but you just don't have, you can sit in the doctor's office for a whole day to get to see the doctor, how is that incorporated?
So it's a great question, and let me say kind of as a high level thing, when people think about health systems more broadly, people think about cost, quality, access as 3 features, right? And if you think about it, anything we consume, purchase, own, use, we think about how much is it going to cost, can I get it, and how good is it going to be. And the truth is, of course, these 3 things are not completely independent. And there are places where they start overlapping. But intellectually, to be able to not just say we're talking about everything, people have drawn boundaries and said, cost is a really important issue, and of course cost influences access and influences quality, because if you can't afford it, then what's the point of having it? But we're going to make some somewhat artificial boundaries. We're going to talk about quality as like the service you get once you're in, access is about can you get in, and cost is how much are you going to pay, and is it going to bankrupt you? Understanding that these three things are not, of course, intellectually completely independent. But it is helpful sometimes just to draw those boundaries to kind of be able to focus on one part of the system and not the whole thing. So that's why the Institute of Medicine and others have drawn these distinctions. Okay. So, yeah. Oh, yes.
I want to ask you about whether psychiatric practices are included in this unsafe care, you know, when if you disagree with a provider that's pathologized and, you know, ECT and all kind of dangerous, toxic psychotropics.
Right. Well, so the big picture I would say is, so global mental health as a important public health issue is both massive and completely underdiagnosed, undertreated. Mental health as a field and how we take care of people who are is I think going through a lot of changes. I think we're getting better at that. There's some disagreement about those therapies. To the extent that there's clear harm that can be quantified in studies, it would have made it in. But this was really based on the evidence and data we had. So this is meant to be a little bit of a provocative question to your question that you had raised. Because in the global health world, we tend to think of the bigger problem as access. And I am going to ask you to work with me for about 5 minutes. I'm going to lay out a case for why access may actually not be that big of a problem, and quality may be a much bigger problem. And this is going to bother you because it should kind of upend some of the thinking that people have had. So just suspend disbelief for a little bit, hear me out, and then go at me as hard as you want. Okay? So access may not be the biggest problem. I am now going to share with you a whole bunch of work that has been done by, a lot of it done by an economist named Jishnu Das, who has been just doing unbelievable work over the last 15 years, and I'll describe it more. But a lot of it is he goes into communities around the world, and he counts up how many people provide care to people. I said people, I didn't say doctors, I didn't say nurses. He counts how many people call themselves doctors, what kind of stuff they do. He trains up standardized patients and he sends them off to clinics to see what happens to them. And he didn't do this as like he did this once for 40 patients in Gujarat. No, he has done this in like 40 different countries, tens of thousands of clinical encounters, and has taught us a lot about what's actually going on in outpatient care around the world. And I want to share some of that data. So he takes an average village in Madhya Pradesh. Madhya Pradesh, for those of you who are from India or know India, it's a pretty, it's not one of the wealthier states, it's a poorer state. He went around to villages in Madhya Pradesh. And what he found, that in a typical village, there are 11 healthcare providers within 3 kilometers. It's a lot for maybe 2,000 people. 71% are in the private sector, practicing on their own. And half of them have no formal training. Didn't go to any school. They call themselves doctor, right? Just set up a little shop. Hi, I'm Dr. Wachter. Not sure I went to medical school. Sorry. I had to get one in. In Delhi, he finds that there are 70 providers within walking distance of every household. Walking distance, 15, 20-minute walking distance. They've gone out and done studies, and they've looked at, like, you can find, I mean, this is like more than Longwood Medical Area, for those of you who know Boston, right, where we think we have, like, more doctors than you can shake a stick at. And this is not just India. He's done this in Kenya. There are an average of 12 facilities providing maternal care per county. There are doctors, and I say that with quotations, everywhere. How good are these doctors? So this is, and again, I could show you studies from lots of different places. This is from a public sector clinic in Delhi. He finds that the average time a doctor spends with a patient is 2.5 minutes. On average, the doctor asks one question during the clinical encounter. Usually, why are you here? It's a good question to start with, by the way. But sometimes a follow-up can be useful. But does less than one physical examination. So those are sort of processes. Doesn't seem like the doctor's doing that much. But then you may ask, okay, well, that's fine. But what I really care about is that the doctor get the diagnosis right and the treatment right. And let me just tell you what he does with standardized patients. He trains up people who are locally from that area. So if he's in Madhya Pradesh, he will go find somebody from a village next door. So they speak the language, et cetera. And that person will get training. And the diseases or the conditions he picks are really straightforward. So he's not trying to do diagnostic dilemmas, right? Like, my ESR is a little bit elevated. I've had this like coming and going phlebitis. No. He's got like a 48-year-old guy who says, I get chest pain when I go upstairs. It gets better when I rest. And by the way, like 6 months ago, it wasn't there at all. In the last couple of weeks, it's really gotten much worse. And if you ask me, I'll tell you that I'm a smoker. And somebody told me that I had high blood pressure, but I don't know what that meant, and I've never done anything about it. Like, it's meant to be that straightforward. And he wants to just get a sense of, like, what do doctors do? And here's the data. And let me just highlight a few things. I'm picking on Bihar because my family's from Bihar, as Kazi said. So the doctors get the correct diagnosis for a kid with a viral diarrhea 3% of the time. That's a hard number to come up with. Like, how do you get the wrong diagnosis 97%? And then one of the metrics uses is that the person got no unnecessary medicines, like anticholinergics for a kid with viral diarrhea. That would be an unnecessary medicine, right? And that number in Bihar is 0. In Delhi, it's better, 8%. This is a negative, so another way of saying is 92% of people got unnecessary treatment. 100% of the kids got unnecessary treatment. In the urban clinics in Delhi, for people coming in with 6 weeks of cough, night sweats, weight loss, right? Like, again, not supposed to be like a medical mystery. What could it be? And the diagnosis, they don't have to make the diagnosis that you have tuberculosis. They have to, like, think of TB, mention it as a possibility, and do a follow-up test, like an X-ray or a PPD or something that says they're thinking TB. And they're doing that 1 out of 3 times. Yes?
What are some of the incorrect diagnoses? Like, what are they diagnosing the diarrhea of kids with?
Yeah, so they've all sorts of things, right? But a lot of it is, you have an abdominal infection, here's some antibiotics. And you can say, well, is that a wrong diagnosis? Maybe. But just, they were looking for something that suggested that the kid had a viral diarrhea that was likely to self-resolve, and they needed fluids, basically, and rehydration. And again, angina, asthma, diarrhea in Madhya Pradesh, right, which is a rural setting. Here's your 12%. This is not an India problem. You're like, he's telling us quality in India is terrible. Quality in India is terrible. It just turns out that it's also a problem in China. These numbers are a little tiny bit better, but not that much better. And then some of the best performance is showing up in Nairobi in an urban clinic where the correct diagnosis is up to 32%, and people are getting no unnecessary treatments half the time. Yes?
Question. You said doctor is over-include. Does that include like witch doctors or,
Yes.
therapists?
Yes. So anybody who calls themselves a doctor is in. So that should bother you, because you're like, whoa, you're talking about a lot of people who have no medical training. I'm going to address that in about 2 minutes. But absolutely, anybody who calls themselves a doctor. And the reason why he uses that as a definition, so that definition drives policy people crazy. Because policy people are like, I don't care about the quack. That doesn't count. I want to know about real doctors. And his point is, if you start with the perspective of the patient in the community, these are the people they're seeing. So let's figure out how good they are as a starting point. And then we'll try to dissect out all the other issues. So I'm going to come back to your point in a second. Any other reflections or thoughts on this? Mimala.
I wonder how much of the high proportion of unnecessary medicines comes from the financial incentive to sell people medicines.
So there is a great study. One of his colleagues was involved in. I love this study, where they were in China. So as you know, doctors get kickbacks for any prescription, right? And so he did a randomized trial where he sent in people with viral syndromes, clear upper respiratory viral syndromes. And half the times, the patient just sort of played out the standard stuff. The other half, the patient said to the doctor during the clinical encounter, by the way, if you're going to give me an antibiotic, just write me a prescription. My brother runs a pharmacy. I'm going to get it filled by him. I.e., there will be no kickback, right? Because usually the doctor will write the prescription and say, go to this pharmacy, and they will fill it for you. So he took the kickback out. And he found that in the control group, the antibiotic prescription was 80%. And in the intervention group, the antibiotic prescription was 13%. So that's not like a 5 percentage point relative risk of 0.8, right? That's a number needed to treat of like 1, right? I mean, it's insane. And it also tells you that the doctors know. It's not like they don't know that they shouldn't give the antibiotic. Everybody knows. It's just, get a little kickback. It's nice. A little extra cash on the side. Yes, Kazi.
To the extent that I'm jumping ahead a little bit, but to the extent that there's difference in quality between the qualified physicians and the unqualified providers.
You are jumping ahead, yes.
Then would coverage actually move people to the qualified providers who could build UHC and therefore improve outcomes?
Yep. So I'm going to make you hold your thought. Okay. Yes.
Do you have similar figures for America?
So we don't, not quite this way, but there have been standardized patients. Actually, when I was a resident here, some folks were doing a standardized patient. The good news is it's much better, right? Especially at UCSF. The Brigham residents, but the bottom line is that we think the correct diagnosis, and again, it sort of depends on what you mean, but my best estimate is that the correct diagnosis in general, not just on the simplest cases, but in general, is probably in the kind of 90 to 95% range, maybe even higher. It depends on like how, in what time period, but like we don't have, this is atrocious. Right? You're going to see a doctor and you're getting the correct diagnosis, like rarely. So the one question that people bring up is the problem that there are just too few of them. And these doctors are getting crushed. They're like so busy. They're flying through these patients, 2 minutes a patient. They don't have time, right? So he did a bunch of time motion studies. And this is just from 3 places. Average time spent seeing patients in a full day. So he just sent research assistants off to clinics to hang out with the doctors, to say how much time does the average doctor actually spend seeing patients in a given day. And he's done this in a bunch of different countries. I'm just going to show you 3 pieces of data. This is from a district hospital in Vietnam, where the average doctor is spending 3 hours a day seeing patients. It's from a rural clinic in Vietnam, where the average doctor is spending 1.1 hours. And this is from a public clinic in Madhya Pradesh. 0.4 hours, it's like 25 minutes in a day. So literally what happens is they're hanging out in clinic. It's a public clinic. They're getting salaried. They're salaried. They're going to be there all day. They see 10 patients, 2 minutes per patient. And the rest of the time, they're hanging out. They're drinking tea. I'm not trying to be facetious. Like, that is what public clinics in large chunks of rural India, rural Tanzania, rural Vietnam looks like. Part of it, and I didn't put in this slide because we could spend the whole time talking about this, is then what happens is these same public providers set up a private clinic on the side. And instead of 2 minutes, you'll get 6. And the correct diagnosis rate goes from about 10% to 40, 50%. And so part of it is that it's sort of lead generation. You go to the public clinic, you realize you're not really getting what you need. And the message is very clear. If you go to the private clinic, you'll get that. So then the question is, how does UHC play into that? So these are public clinics which are already accessible. But then if UHC lets you go see the private provider, the same provider in the private clinic, it's just sort of funny because like the government's paying for it in the public clinic and then they're going to pay for it in your private clinic. It sets up all sorts of funny incentives. Questions or comments on that? By the way, when I first saw this data, I didn't believe it. Because the idea that most doctors in low-income countries were sitting around not actually seeing patients for most of the day didn't seem to me to be plausible. And these are time motion studies, unless all these researchers are just faking data, which I don't think they are. There are a couple of exceptions in very, very busy public clinics in hospitals in like big urban centers. So you go to Delhi, you go to a public hospital, you go to their outpatient clinic, they're seeing 200 patients in an afternoon. And the quality in those is much, much better. But in these public clinics and private clinics across the rest of the country, not so much. Yes?
Yeah, I guess I just wanted to talk. My experience is that I'm not surprised by the state of Madhya Pradesh, for sure. That's a little shocking. But in Kenya, you know, you'll often go and services are provided in the morning. And there is a demand factor, which is that in rural areas, not urban, so all of this you'd have to say rural, urban, but in rural areas people work and they come in early and they're clustered, you know, they're grouped, they're batched.
Yep.
And so there's a service delivery component which is related to quality, but it's the way things are done. And then there's also, you know, clinics are often open 5 days a week, but certain clinics are only on Monday and Wednesday or only Tuesday and Thursday. I mean, there's all manner of health system functioning that kind of explain this. But this has been my experience. You go to any health clinic in almost any country in the afternoon, and it's pretty quiet.
Yep.
They're not drinking tea. They're actually not there. So.
Or they're home. Yeah, they're home. Or they're running the private clinic down the street. Andy.
So, Ashish, I mean, the two concepts of your two outcomes are kind of related, aren't they? I mean, in the ACA kind of got at this. You mentioned the caps, but the bigger related issue was the metal tiers and kind of defining what health insurance is, because prior to the ACA, we're all reading newspaper articles about, gee, I thought I had health insurance until I got sick, and then the small print said, except if you get sick.
Right.
And this is the equivalent, obviously, for doctors, which is like, what do we mean by a doctor, or what do we mean by health care?
Yeah.
It'd be interesting to see, maybe you have data by countries about what kind of regulatory things they have in place, licensing, different ways of monitoring quality to see if, in fact, it impacts these things. Because laying a sort of a payment card on top of a corrupt system, which is what you're describing, is obviously not a good thing.
Yeah.
Whereas laying that on top of something where there's some standards maybe starts to, in fact, give you the kind of interaction that would be more beneficial.
Absolutely. And so I don't have that slide, but I'm going to, in about a minute, I'm going to actually address that issue directly because that's a really important point. So let me see if I can get to it in a second. Let me just show you one slide. I've told you that at least from that India study, half the doctors were fake. Right? These are people who didn't actually have any formal training. And so if they don't have formal training, then like what are we talking about? And of course, the strategy in India has been lock up all those people and just train more real doctors who went to real medical schools, and that'll fix things. And so the idea is if we just had real doctors, wouldn't that really help a lot? And so there's a really basic question, which you'd think the answer ought to be yes, which is, does qualification lead to better knowledge and quality? And so this is data from Vietnam, but there's actually even better data on this from India. But I didn't want to just show you lots and lots of data from India. So here's a study from Vietnam, where he actually did a whole bunch of testing of doctors, both real doctors and fake doctors, on a whole bunch of knowledge stuff. And you could score from 0 to 7, 7 really being you knew all of the questions about, like, is this asthma? What's the next test? What do you do for TB? What do you do for a management of angina? And 0 is like, you have no idea. You've never heard of this thing. And so here are the data. This is the distribution for people without a degree. And this is the distribution for people with a medical degree. And what he's found in India, for instance, is that the average doctor who did not go to medical school in South India is much better than the average doctor who did go to medical school in North India. And if you know anything about the south and north of India, you won't be surprised, and I, being from the north of India, am not surprised, and yet there it is. The average, okay, let me just be very clear. The average person who did not go to medical school in South India has higher knowledge and higher quality than the average person who did go to medical school in North India. I am not saying there is no relationship between going to medical school and understanding medicine. I'm just saying it's a really, really weak one. Especially the North. And again, from Bihar, like that pains me. I did not go to a medical school in Bihar, by the way, just for anybody who's... I did go to a medical school in the North. But we're not going to go there. So what's this about? I want like one explanation on this, anybody. Because this is crazy, right? Like, doesn't this bother somebody to say, you went to medical school and you're not better than somebody who didn't go to medical school in terms of knowledge? Back there.
So I was working in India for about 6 months, and we had training some medical residents.
Yeah.
It was interesting. I mean, the ones who went to medical schools that were publicly funded were actually great.
Yes.
They were brilliant, brilliant.
Yeah.
And there were a couple who somehow went into these private medical schools,
Yeah.
which it sounds like their dad was rich, they paid off the
Yeah.
dean or whatever. And
Yeah.
this guy couldn't, I mean, he was
Yeah.
terrible.
Yeah.
And so this doesn't surprise me at all.
Yeah.
Probably thousands of people. Similar.
Yeah, no, I think that's right. That's right. So the ability, and this is going to get to Andy's, and I don't have a slide on the point that you're making, but it's actually such an important point, so I'm going to take a minute and talk about this. Which is, if you ask, do these countries not have, like, licensing? Regulatory ability? Don't they have regulations? Like, if I wanted, well, I actually did go to medical school, but imagine, like, I hadn't, and I decided I was going to set up practice. Like, I'd be caught pretty quickly. I'd probably end up in jail. We've all heard about the people who, like, faked it for years. But those are very rare, right? The laws in India are no weaker than the laws in America. The licensing requirements are not much different than they are. They're mostly just using the UK model. It is the capacity of the state to execute. So the biggest problem with regulating healthcare in low and middle income countries is about regulatory capacity of the state. So people, this debate we have in America about innovation versus regulation, that is not a debate in India. Because if you can't regulate, if you can't enforce your laws, if a majority of the people who are practicing as doctors in your country never went to medical school, that's a different issue. But the truth is, that's what we have. This is Vietnam, but that's what we have in India. And that's, in China, it's a little different. But the knowledge variation and quality stuff in China is really quite stunning as well. All right, I have about 7 minutes. So what have we learned? Doctors are ubiquitous. We've got no shortage of people who are doctors. Quality is abysmal. Patients get private care when publicly available. I didn't show you the data on this, but I made this point that lots of times, remember I said 70% of primary care in India, for instance, is private, where public is often available, just people choose not to go there because they know the quality is going to be abysmal. Doctors are not all that busy, and I put 2 asterisks just to remind myself and you, and I had already made this point, that there are exceptions to this in public clinics, in public hospitals in large urban centers. Doctors are insanely busy, and the quality tends to be high. And that's not a volume-outcome relationship, it's an outcome-volume relationship. Quality is good, and that's why everybody goes there. And people say, oh, if we could just keep people out of here and get them to get care locally. And patients are just way too smart for that. They're like, get abysmal care locally, or make the trek into the city and get good care. I'll take the good care. And that's why people travel. Yes?
You said that the same doctors had their practice and better clinicians in the private sector.
Yes. So the salaries are low. And so one thing you could do is increase salaries. But all of this is just, it's money coming from somewhere, right? Qualifications is not quality. I'm going to take a minute to talk about something that many of you know about. This is one of the places where I think the global health policy world got something very fundamentally wrong, and it makes a lot of sense why they got it wrong. And when you see the data of what happened, it makes a lot of sense. like what happens. Let me just tell you the story, and I'm going to just take 2 minutes. We know maternal mortality is one of the big global health priorities. We also know that like it is just from a societal, economic, human welfare point of view, like one of the very big issues facing humanity. We've got to figure out how to reduce maternal mortality rates. And so one of the things is from a WHO study from about 10 years ago. When they looked at maternal mortality rates and facility deliveries, there's a nice negative slope, right? Countries that have higher rates of facility deliveries have lower mortality. This is not shocking. And people have seen this kind of data for a long time. This is just one slide. But literally, there are hundreds of slides like this. And so the analysis that came out of that was really very straightforward, which is that the lack of facility-based births was a key reason why many women were dying during childbirth. Makes sense. You can see the data. More facility births, lower mortality. What's the policy prescription? Really straightforward. Get women to deliver their babies in institutions. And so lots of countries, Rwanda, Tanzania, India, put in big bucks. In India, it was hundreds and hundreds of millions of dollars to pay women to go deliver in institutions. And what we saw was massive increases in institutional deliveries. Uttar Pradesh and Bihar, right? Uttar Pradesh is 250 million people, Bihar is 150 million people. Like, these are states, but they're like bigger than most countries, right? I think Uttar Pradesh saw institutional delivery rates go from like 28% to like 70% for a population of 250 million people. Massive. And so that was the good news. The bad news was nothing happened. Mortality did not budge. This is just one slide. There's a paper in Lancet on this that really plots out what happened with institutional deliveries. Institutional deliveries went up. Maternal mortality didn't fall. Infant mortality didn't fall. Nothing happened. And I think it's because we misunderstood why women don't deliver in institutions. Women are pretty motivated not to die during childbirth. And you don't need to bribe them. They weren't going to facilities because the facilities were terrible. But they were poor, and you give them enough money and they'll go. Right? We focused on coverage over quality. We spent lots of money and made very little progress. Okay. We have 4 minutes. I have a third point that I was going to make, and it's going to take me more than that. So let me just show you one slide. I'm going to show you one slide. This is we've been talking about kind of mostly low and middle income countries. This is a slide from a high income place called Massachusetts. And in Massachusetts, we did something called universal health coverage. In 2006, we passed Massachusetts health reform, the basis for the Affordable Care Act. And I want to just show a little data about what happened to Massachusetts spending on a bunch of stuff. And so this is changes in Massachusetts state spending 2001 to 2010, 2001 in red, 2010 in blue, in billions of dollars. And this is from the Massachusetts Budget Policy Priorities group that tracks this stuff. And if you look at spending across a variety of things in Massachusetts over that decade when we did health reform. By the way, Massachusetts is a pretty wealthy state, so lots of dollars. Like I think the second or third wealthiest state in the country. And we were already starting off with a baseline insured rate of about 91%. So we went from about 91 to about 98. So it wasn't like a massive thing, right? And what we saw was that mental health spending in Massachusetts declined 22% over the decade. Public health spending dropped 31%. Education used to be the #1 ticket item for the state. That dropped 12%. Infrastructure, roads and bridges fell 14%. Law and public safety fell 13%. Local aid to cities and towns fell 51%. And guess where all that money went? Healthcare. Is this a bad policy decision? I mean, it was a policy decision. But the point is, when you have fixed budgets, the money has got to come from somewhere. And you can't just sort of, I mean, I guess you can just tax people more. But if you want to stay in office, at least in the United States, that's a hard strategy to execute. And so the point on this slide is even in wealthy places, when we do universal coverage, we usually get the money from somewhere. And I am not arguing that putting money into healthcare by taking it out of education, mental health, public health, this stuff is bad. But I'm saying it's at least a question that we should think about. And if you're going to ask poor and middle income countries to put in a whole bunch of money into universal health coverage, you know it's going to come from somewhere. And so the question is, where is it going to come from? And it's at least worth thinking about. I have a slide on what we know are like the big bangs for the buck. There's a lot of things we can do, women's education, other things that give us a lot, big returns. Anyway, just kind of finishing off here. You know, one of the things is if you put a lot of money into universal health coverage, you're going to potentially put in less money on other things that are, for instance, social determinants of health, education, sanitation. Limited resources means priority. And if UHC can and should be a priority, but we have to understand its costs. Last slide, and then I will stop and see if there's any last-minute questions. So I do think we are at a critical moment in healthcare. This is a very much a global health moment. There's been a tremendous amount of interest in UHC. It has become the mantra of the day, and I don't say that to demean it. I think it's a very important goal. Our job, going back to that quote from Martin Luther King Jr., is to examine it intensively and critically and say, is this exactly what we want to do and how we want to do it? I think UHC can be a very powerful tool, but we do have to think about what is adequate coverage that's going to provide financial protection. How do we make sure that we're covering care that is good? And how do we make sure we're aware of the trade-offs? So I am good on making a commitment to making UHC a reality, but we've got to make a commitment to doing it the right way. Thank you. Question? We're at 3:45. One or two, or two questions?
Bringing that financial protection and quality together,
Yeah.
How much of the financial risk comes from low quality care?
Yeah.
So if you think about financial risk, I normally think of it from going to a hospital that you can't afford and spending a lot of money on a lot of different types of care.
Yeah.
And so we've been talking about them separately, but I think they're very much overlapped, and solving one doesn't necessarily ruin the other.
I agree. They are linked. We think that poor quality care generates a whole bunch of additional costs. And of course, you can argue that if you don't have financial protection, you're going to often pick services that are cheaper but may not be as good for you. So there are these intricacies and links between them. And our goal is to have universal health coverage programs that deal with both, right? That both offer financial protection. A lot of the financial protection is from when people get really sick. They get cancer and they need chemotherapy. They have a heart attack and they need heart bypass surgery. They get hit by a car and they need surgery for their, for their broken bones. Those are the big expensive items. It's not unlike here, where we really, really need protection. But those are also the big quality moments where things can go very awry. One more. Over there. Yeah.
So I just wanted to say that, not many people talk about the financial incentives that providers have in low and middle income countries.
Yeah.
And from personal experience, I feel that that is a major driver of the kind of care that providers give to their patients.
Yeah.
So I wanted to get your thoughts on, how you think maybe universal healthcare could kind of fix it, or why more people are not talking about it? That seems to be the underlying, problem with low and middle income countries.
Yeah. Yeah, so getting provider incentives right is unbelievably hard. Like, I don't know any country, any health system that's really nailed that down, right? We have been trying in our country for a long time. Pay for performance, accountable care. It's just fundamentally hard stuff. If you just salary everybody, as they do in the public sector in India, what happens is people spend 20 minutes a day seeing patients. Right? I'm salaried. If you let it go completely to the private sector, what you see is a lot of intensity and a lot of overcharging and a lot of bilking of people who can't afford it. And so I wish I had an easy answer, like if everybody just did X, we'd get the provider incentives right. There are a lot of very smart people in this room who've done a lot of thinking and working on that, and so I'm happy to hear if other people have better ideas. But provider incentives is like, somebody once said, there are lots of bad ways of paying doctors. We just don't know of a good way to do it. And that's a bit of where we are. All right, I think we're good. Thank you again for having me here.